bill. And I have a bill, but it's not their bill.
Before I start the meeting, I just want to mention,
You're on.
good afternoon. Today is Wednesday, January 17th. You're in the Senate Finance Committee, and today we're going to just have two briefings, and I appreciate our folks that are here. First, we're going to have the update from the Maryland Insurance Administration. So in the next 45 minutes, they'll be presenting issues with the Insurance Administration, and we will have our Commissioner Kathleen Brain on Zoom. She couldn't be here in person today. So if I can have everyone else from the Insurance Administration that's here come to the table, please. And with that, I think, can we bring Ms. Brain into the room? There she is. Thank you.
Thank you very much, Madam Chair and members of the committee, and I particularly appreciate your graciousness in allowing me to appear virtually. I am ill, and so I did not want to subject anybody to that. My very capable team is going to lead us through most of the slide deck that we have put together. And so with that, our approach today, we have 4 topics that the committee has asked us to address. The 2024 health insurance rates for the ACA market, an update on trends in property and casualty personal lines rates, the recommendations that the HB 413 work group provided, and information about the MIA's new Consumer Healthcare Access Program. So with that, I think we can get started with the 2024 health insurance rates, and Adam Zimmerman, who is our senior actuary at the MIA, will take us through that.
Can you go to the slide 4, please?
Thank you, Commissioner. So I think she just sent it to Adam. Is Adam here?
Yes.
You're going to start the presentation. Adam, it's up to you. Thank you.
Thank you. As the commissioner said, my name is Adam Zimmerman. I'm a senior actuary with the Maryland Insurance Administration, and I'm going to be providing an overview of the 2024 ACA rates in both the individual and small group market. Excuse me. For all rate review, the insurance article tasks us to ensure that rates are not excessive, inadequate, or unfairly discriminatory, and they must be reasonable in relation to benefits. And so in ACA, it's a unique market because after implementation, health status cannot be taken into account. And as these products are guaranteed issue, and the carrier must use a single risk pool methodology where health status of the entire pool is used to set the rates and not the health status of members in any one plan. So for 2024, we begin by reviewing the 2022 experience period claims data, and that gets projected from 2022 to 2024 to set the rates. And while reviewing that, we compared how the 2022 data compared to prior year's experience, as well as how it compared to how carriers thought 2022 data would turn out when they set their rates for 2022 back in 2020. We review trend. One of the things we review is trend by both cost and utilization assumptions by the various categories: inpatient, hospital, outpatient, hospital, professional, and prescription drug. And other key assumptions for setting the 2024 rates included morbidity, which is the relative health status of the pool. We reviewed the operating expenses and profit margin for each of the companies, as well as risk adjustment transfers. And risk adjustment transfers are unique to the ACA market because of the single risk pool concept. Carriers who attract healthier members than average have to make risk adjustment payments to the carriers who attract sicker than average members in order to help even out the premiums and not rate based on health status differences between the various companies. Another thing we looked at was the COVID-19 impact. That's at this point mostly in the rearview mirror. However, the claims trend we review is for the past 3 years. So that did include 2020 data, at which time early on in the pandemic, there was the shutdowns. And so that greatly distorted carriers' claims during that time, and adjustments needed to be made when analyzing the claims trend. And then finally, outside of that, in the individual market, we have the reinsurance program, which we reviewed, as well as the impact of the Medicaid unwinding. As the COVID-19 public health emergency has ended, people are being disenrolled from Medicaid, and we'll continue to keep an eye on that as it goes for another 6 months, but the carriers did not make a huge impact as a result of this unwinding. And so the rates were submitted in the end of May 22nd. They were revised in July, and that's for changes to both the risk adjustment program and the reinsurance program changes. And then we finally approved them in September of 2023. Next slide, please. So here's a comparison of the 3 markets: individual, small group, and the standalone dental. The left-hand or the middle column represents the requested amounts initially requested, and then the right-hand column represents the approved amounts. You'll note for individual, the initial request was 5.7, and then after the updates in July to account for changes that were made to the reinsurance program, which I'll discuss on the next slide, as well as CMS releasing the 2022 final risk adjustment results, that was then amended to 6.3% rate request. But we ultimately ended up approving a 4.7 average rate request in the individual market. Small group, the average request was 7.5, and we approved the 6.9% rate increase on average. And then in the standalone dental market, we approved what was requested at minus 1.3%. Next slide. So as an overview of the individual market for 2024, as I pointed out from the previous slide, the carriers originally asked for an average 5.7% rate increase, which was adjusted in July up to 6.3, and we ultimately approved an average rate increase of 4.7%. For both CareFirst PPO product and the United product, which comprises approximately 17% of the market, the average rates, the rates will be decreasing for those carriers. We had Aetna enter the market in 2024 with 9 plans as a new entrant, and they'll be offered statewide. So now we have all counties have at least 3 carriers to choose from, but the metro counties will have 4. The reinsurance attachment point in 2023 was lowered from 20,000 to 18,500. And that was in response to the enhanced subsidies being offered under the American Rescue Plan Act. Unclear on if they would continue or not. At the time, we approved 2023 rates. And in the event that those subsidies were not extended, there was going to be a huge market disruption in terms of large premium rate increases being seen and a large exodus from the market. So in order to combat against that, we lowered the attachment point, which reduced rates further in 2023. And then for 2024 rates, it was announced that the enhanced subsidies offered under the American Rescue Plan Act would be extended through the end of 2025 when the Inflation Reduction Act was passed. And so in interest of the long-term solvency of the program, the MHPE board voted to increase the attachment point back up to $20,000 from $18,500. And that $20,000 level for the attachment point is the same level it had been at since the start of the program from 2019 to 2022. So this change in the attachment point put about 1.6% pressure, upward pressure on rates. And so if we had left the attachment point untouched in 2023 and left it at $20,000, last year's approvals would have been over 8%, and this year's approvals would have been closer to 3%. But as I pointed out, we ended up approving 4.7% as a result of adjusting the attachment point. And in the individual market, the low increase for 2024 was driven by 2022 claims trend coming in lower than the carriers originally projected and fairly low pricing trends. On average, we approved a 5.3% pricing trend. And as a result of the reinsurance program, when talking about unsubsidized rates, since 2021, Maryland residents have had the lowest bronze and gold premiums in the nation and the third lowest unsubsidized silver premiums in the nation. Next slide, please. So this chart here walks through the rate approvals that were filed and approved. What is of interest should be the last three columns, and those that are highlighted in yellow. As you'll see, filed, the third most column from the right, 5.7 initially filed. And then we approved 4.7% on average. And as I pointed out, you can see for the two CareFirst PPO entities, their average rate change is negative, as well as the Optimum Choice UHC United entity. And one thing I want to point out is that since the inception of the reinsurance program started, that leftmost column has shown that in the leftmost column with the highlights has shown that from 2019 to 2021, the program has caused rates in the individual market to decrease on average 31%. And since then, they've increased slightly, which is the intent of the program. The first 3 years was to reduce rates by 30% and then increase each year by claims trend or near claims trend. And so in the far right column, that minus 21.9 is showing that on average, since the inception of the reinsurance program, rates are approximately 22% lower in the individual market than they were in 2018 before the program went into place. Next slide, please. These next few slides, I'm not going to spend a whole lot of time talking about, but they provide some illustrative examples. For this example, there's going to be 4 slides. There's going to be one for bronze, silver, gold, and then there's also one for value premiums. And if you could go back one, yeah, okay, bronze is fine. The leftmost in all of these slides, the left table represents a comparison of 2023 to 2024 premiums. Again, these are unsubsidized premiums for those that aren't eligible for any sort of subsidies for a 40-year-old in the Baltimore metro region. And the table on the right is for a family of 4, again, in the Baltimore region. We picked age 45, 43, 15, and 13. And it provides a comparison of, how rates have changed from 23 to 24. And in all of those slides, that's the tables are the same representation. Keep going. All right. Thank you. For the individual dental market, as I pointed out in a previous slide, we approved what was initially requested, which was an average rate decrease of minus 1.3%. And with this approval in 2024, 75% of the dental policyholders will be receiving rate decreases. The 2 carriers that we approved rate increases for, which are Alpha and Delta, the requested rate increase equals the decrease that they implemented in 2023. So the 2-year average is essentially a 0% rate increase over that time. And the reason why these rates are, average rate decreases is because the claims trend in dental remain very, very low compared to medical. There's not a lot of high dollar dental expenses or high dollar claimants in the dental market, which are increasing dental trends. Again, this is a comparison table similar to what was provided for the individual market. The 2 rightmost columns show what was requested and approved. And in this instance, since we approved what was requested, both of those columns are the same. Next slide. For small group ACA, carriers initially requested an average rate increase of 7.5%, and we ended up approving a slightly lower rate increase of 6.9%. In the small group market, all carriers filed for rate increases with significant variation between the carriers. What the major driver of the increase in the small group market was trend. We approved a small group trend of 7.8%, which is significantly higher than the 5.3 we approved in the individual market. But in the small group trends, the high prescription drug costs is the main service driver driving this higher trend. And the one thing we will say is that while the 7.8% average trend we approved is higher in the individual market, this trend is still in line, with large group and national trends. Studies that show group trends are continuing to increase. And then lastly, on the last bullet point, even though that the small group trends are higher than an individual, small group claims remain significantly lower. So for 2022, the small group average claim was $502. And in the individual market, the small group average change was $623, which highlights the need for the reinsurance program in the individual market. The claims are approximately 25% higher in the individual market. And that's mainly driven by the fact that, as I pointed out, you can no longer health underwrite in the individual market. So when the ACA first started, a bunch of very sick people who couldn't get coverage pre-ACA when they needed to pass medical underwriting, and only the healthiest members were enrolled in coverage. They were now eligible for coverage, entered the pool, and started to rack up some high dollar claims. And then this is a table that represents the small group ACA approvals. The two columns that we should be looking at are the far right. That shows the approval by each carrier, final approval average, that shows a 6.9. And then the other bolded one with in the middle that originally filed, that shows the originally filed requests. The one thing that differs between individual and small group is that in the individual market, or excuse me, in the small group market, the rate changes are quarterly. And this is because carriers can pre-file trend increases, and depending upon how the trends compare from last year to this year, depends on how the overall rate increase by quarter is being calculated. And in addition, in the small group market, carriers, unlike in the individual market, if carriers realize that their trends are coming in higher than they have originally pre-filed for, they can submit mid-quarter, mid-cycle reviews and file, quarterly rate changes with updated trends. And we've seen some of that in the last few years. So that's why there's variation among the various quarters, but the variation is not, extremely off. It's 6.4 is the low in the second quarter, and the average 7.4 is the high in the first quarter of 24. Next slide, please. And then these last two slides show in the small group market the average premiums. Again, the far left is for an individual. The right table is for the same family of four. The one thing I will point out is that in the small group market, oftentimes the employer subsidizes premiums to some extent. So oftentimes the insured is not paying the full amount of these premiums, as the employer subsidizes it, some portion, all of it, or some portion of the total premium. Next slide. And then this is for gold. The last one was for silver plans, and that's for gold.
Do I have any questions for Adam Zimmerman?
Yeah, thank you, Madam Chair. Really quick question. Thank you for your presentation. So one of the charts I was noticing, you have a Aetna. There are two Aetnas with different plans.
Right.
Are those are they separate companies and totally separate plans, or?
Yeah, one's the PPO company and one's the HMO company.
So they're totally separate companies?
They're separate companies,
Okay.
yes.
Okay, great. Thanks. Didn't know that.
Thank you, Mr. Zimmerman. And who's next?
Good afternoon, Chair Bidle, Senators. Thank you for the opportunity to address the committee on personal lines insurance rate trends, specifically automobile and homeowners. I'm Bill Fawcett. I'm the Associate Commissioner for Property and Casualty Insurance at the Maryland Insurance Administration. You have the first slide. Thank you. So all insurance companies selling property, casualty, surety, mortgage, guarantee, and title insurance in the state must file their rates, their rating plans, and rating rules with the Maryland Insurance Administration. The Property and Casualty Division, Rates and Forms Unit, reviews these filings, ensuring that rates are actuarially justified and not inadequate, excessive, or unfairly discriminatory. The level of review by our insurance professionals and actuaries, it will depend upon the product line. For personal automobile and homeowners rates, Maryland is a file and use jurisdiction. Under this system, insurance companies file their rates and may use rates without the Maryland Insurance Administration's prior approval. Filed rates may not be disapproved for being excessive unless the Maryland Insurance Administration determines, after hearing, that the market for this line of business is not competitive. During 2023, personal automobile companies filed new rates. The chart on this page shows the top 10 personal automobile insurance insurers in Maryland based upon their market share. Market share is determined by the amount of direct premiums written by the company divided by the total premiums divided by all insurers in the market. Insurers file rates with an indicated range of change required to meet their business objectives. Within that range, an insurer will take a rate which is what impacts policyholders. For the top 10 insurance companies, the average indicated rate change in 2023 was 15.6%, and the average impact on consumers was an 8.2% increase. It's important to note that Maryland is not unique in this respect. Every state in the country is experiencing similar rate increases. Auto rate increases are being driven by increased frequency and severity. Next slide, please. The drivers of these changes: auto rate increases are being driven by increased frequency and severity of claims for accidents, as well as theft claims. The cost of property claims under the auto policies are increasing due to general inflationary pressure, including the increased cost of labor and materials. Car parts are more technologically sophisticated and expensive in the past, and this is driving additional costs and pressure. More vehicles are being declared total losses, and there are lingering supply chain issues, and labor challenges are increasing the cost of ancillary claims. For injuries under the auto policies, insurers are reporting an increase in the severity of third-party or injury claims and increased litigation costs. The increase in medical costs is also contributing to the inflation of claims costs. In addition to claims, insurers' reinsurance costs are rising and capacity is being restricted. Maryland, again, is not unique in this situation, and reinsurance is a global product, and all states are being affected by these rates. Next slide, please. Similar to the 2 slides ago, Maryland homeowners rates are also increasing during 2023. The chart that you have before you shows the top 10 homeowners insurers by market share. For these companies, the average indicated rate increase was 17.1%, and the average impact on policyholders was a 12% increase. The increase in homeowners rates were driven by general economic conditions, including labor and material inflation and supply chain challenges. The increased frequency and severity of claims contributes to rising insurance rates. Severe weather events, including severe convective storms, is a driver of higher claim costs, especially in Maryland. Insurers are reporting a general rise in demands, settlements, and judgments, which we refer to as social inflation. Insurance fraud and solicited claims like hidden roof or siding damage also contribute to the rise in rates. Deteriorating financial performance amongst homeowners insurers is placing pressure on insurers to raise rates. Additionally, homeowners insurers are encountering decreased reinsurance capacity and increased insurance costs. And while Maryland is not considered a catastrophe-exposed state, our insurers are affected by the global results of weather and climate events that the reinsurance industry takes into account. Thank you for your attention. The commissioner and I would be happy to respond to questions.
Thank you, Mr. Fawcett. Do I have any questions from committee? I have a few questions, if you don't mind.
Yes, ma'am.
How often, when you receive the file and use rates, does the insurance commissioner go back and change the rate? Does that ever happen, or is typically the companies are very accurate in their rate filings?
We rarely, I can't even remember the last time that occurred. And the reason for that is that we do challenge companies on what so the rates are not a single rate, right? So there are factors, complicated factors, many factors. They have a base rate. And then, as you know, probably better than I do, those rates can go up or down based on factors. So our actuaries do look at those factor level changes and they question the companies about it. And as a result of those conversations, the companies may withdraw a factor or they may modify a factor. So that's the normal cadence, is discussion and coming to a reasonable accord. We don't have a tool that we have in other circumstances, which is to say, I'm sorry, at the end of the day, I think what you're putting in for that factor is excessive. And so I can't change their rate for that reason. As long as the rates are not inadequate, and it's not as long as they are not unfairly discriminatory, which really looks at the fairness of the factor and whether the factor is really indicative, statistically indicative of risk, we don't have the ability to tell a company, don't use that factor, or you're charging too much for that factor. it's really more than anything, if you will, a relational issue of making our concerns known.
Thank you for that. And my other question has to do with the changes in the rate for homeowners. So we know that there was an increase due to some of the cost of rebuilding and materials, but does this include the increase that we see in property assessments? Because like a lot of the assessments have increased significantly, which then affects the homeowner's rate. So, or is this just based on, rate to rate without the increase in assessment?
I would want to dig a little bit deeper into that, Senator, because I'll tell you one of the biggest issues nationally with PNC carriers is that there is a and part of what's driving is the rate changes is that the value of property is often not updated. So the premium being charged is not commensurate with the risk because those value propositions that are part of the premium determination are not regularly increased. And so that has become part of a national conversation about making sure that risk is accurately assessed. So that is an area that I'm happy to look into a little bit more deeply and what's happening in Maryland right now on that front.
Thank you very much, Commissioner. Who will be next? Who will be presenting next?
Me. Thank you. So thank you for the opportunity to talk about our HB 413 report. Just as a matter of, if you want to hit the next slide, please. Thanks. So House Bill 413, which was enacted in the 2022 session of the Maryland General Assembly, directed the Maryland Insurance Administration in consultation with the Maryland Health Benefit Exchange and the Maryland Health Care Commission to report to the governor and the General Assembly on the impact of the state reinsurance program. And in developing that report, our direction was to focus really in three areas. The first area is the design and the parameters of the program generally, and whether they remain appropriate in light of other state and federal market reforms that have evolved since the state reinsurance program was established. The second area of focus was about the level of funding for the program, as well as the source of funding and the allocation of the funding. And then finally, we were asked to consider other market reforms that are needed to provide affordable health coverage in the individual market, including state-based premium subsidies and what would be the potential, what would it mean if Medicaid eligibility were expanded. So with that charge, we put together a working group which consisted of state agencies, obviously the MIA, MHBE, and MHCC, but also many divisions of the Maryland Department of Health. And so representatives of those agencies worked together to do the analysis, to do the modeling work. We also sought stakeholder and public input through 5 public stakeholder meetings where we discussed our analysis, gave our preliminary findings, answered questions, and then invited follow-up comments, which we did receive in some cases. So our very dense and very detailed report is available to review, and we are very happy to meet with any member of the committee or staff to review our findings in detail. But today, I'm happy to review the recommendations in the report at a slightly higher level, and then, of course, entertain any questions that you have. And Adam Zimmerman, who is here with me today and is a senior actuary of the MIA, who was very involved in the modeling effort, will be able to answer all the math questions that I will not be able to answer. So next slide, please. So if we look at our analysis, right, this slide sort of lays out what did we focus on. So we wanted to take a look at the reinsurance program design and funding. And to do that, we did a comparison of the size of our program and the design parameters to the design and size of the programs in 16 other states that have reinsurance programs. We also looked at them in light of other federal and state market reforms and what, if any, impact those other state and federal market reforms would have had on our reinsurance program. We looked at the impact of federal subsidies and the consideration of what potential changes in those federal subsidies would mean for the state reinsurance program, most significantly the sunset of ARPA at the end of 2025, if that is not, if it's not continued. And then we did look at how other states fund their reinsurance programs in terms of just the pure reinsurance and then, of course, other market reforms. We also identified sort of 4 categories of state-based market reforms that other states have employed or deployed in various levels at various mechanisms. And many of these are evolving, right? So state reinsurance programs and the waiver process haven't been in effect for very long, and states are gradually moving and growing in the area where they're adding to subsidies in order as they develop and understand where additional support is going to improve the availability and the accessibility of insurance in the individual market. So we looked at 4 concepts. First, and probably most importantly, at the continuation of the young adult subsidy program. Then we looked at what other states are doing and what it would mean for Maryland if we were to broaden that program into a subsidy program that's not determined merely by age. We also looked at what would be the impact if Maryland were to adopt what a small number of states have begun to look at, which is a state-based cost-sharing subsidy program. And then finally, we looked at what would it mean for there to be state-based premium subsidies for some or all undocumented persons. And we evaluated that by age cohort to be able to give you information about what that would cost the state if we were to implement that or any part of it. So if we move to the next slide, I'm not going to spend a lot of time on the young adult subsidy program because the success of that program and where it is right now is really for MHBE. And I know they're going to be coming up after we do to speak. And so I'm going to leave it to them to talk generally about the young adult subsidy program, but I will note that the young adult subsidy program has not heretofore exceeded the $20 million that's been allocated to fund it. It's always been under that amount. It has been a particularly important tool this year in connection and as a result of the Medicaid unwind. There are a large number of people who are young adults who have moved into private health insurance on the exchange as a result of the Medicaid unwind. And so the large number, the percentage, relatively high percentage of those people that are young adults have really benefited significantly from the existence of the young adult subsidy program. And again, MHBE will address that in more detail. We also, as I mentioned before, if we go to the next slide, please. The general state-based subsidy programs. So there are a number of states that have adopted state-based premium subsidies that are not linked to age alone. And so we modeled what that would look like for Maryland if we were to adopt state-based subsidy programs that would be on top of what the federal government pays. And we modeled that at $40 per person, 75, I should say per policy, 75, 100, and 125 per member per month. So as we looked at that modeling, we are able to, and again, the report goes into a great deal of detail about what other states are doing this, what preliminary analysis is about the kinds of impacts that this is having. But ultimately, if we were to adopt that, the cost to the state would be between $46 million and $148 million, depending on the generosity of the subsidy, which would begin for the first time in 2026. Next slide, please. We also looked at a state-based cost-sharing subsidy. Originally, the ACA did provide for cost-sharing subsidies that have, but that has evolved, shall we say, and the federal funding for that has altered. And so some states have, a small number of states have begun to look at replacing some of that cost-sharing support. We have not done any formal studies or any formal surveys, but apocryphally, and particularly Ms. Hatchett, Associate Commissioner Hatchett, who leads our consumer education and advocacy team and is Our people are on the ground all over our state, a lot, 600 in-person events last year. And one of the things and one of the concerns they hear are sometimes it's not the cost just of the premium, it's the cost of the copay or the deductible. So it may very well be that you have really great preventative services, but if you have an ER admission, you may have very large expenses or, certain types of procedures, et cetera. So some states have begun to look at whether or not it's appropriate for states to subsidize, again, the cost sharing component. We don't have a lot of data on the impact of these programs because they are very, very new. We can tell you and when I say impact, I mean the impact on keeping people insured and keeping people enrolled or increasing our enrollment and decreasing our uninsured population. We did our estimates looking at what it would mean to provide these, and depending on what range we go with, we could be looking at about $33.5 million annually for a cost sharing program that's similar to what some other states are doing. The next slide, please. And then finally, and I think very importantly, we looked at what is the cost of making subsidies available to people who, because of their undocumented status, above Medicaid income thresholds, are unable to obtain federal subsidies. So all of the modeling assumptions are outlined in detail in the report, and within the report, they are broken down by age cohorts. And so the cost to help members of this population to be able to access affordable health insurance is between $48.8 million and $152.4 million. It is certainly true that a person who is undocumented can buy a health insurance policy in the individual market, not on the exchange, but outside the exchange. However, they have to be able to afford that product. So the numbers that you've seen, many people receive subsidies through the exchange. No undocumented person can do that. So they would have to pay the full amount. Right now, there is a very low percentage of undocumented persons who actually obtain health insurance because of the affordability factor. And I think in addition to the affordability factor, it also leads to a fraud factor. So what we have seen over and over again is people who are easily convinced to buy inferior products because they don't have a tool like the exchange that helps them to really understand what it is that they're trying to buy and to understand what ACA coverage means versus what they are often told they're getting, when in fact it's just somebody cobbling together a bunch of not very helpful or generous supplemental benefits that are being sold. And we've had several orders that we've issued this year to producers in that area, but it's a little bit like whack-a-mole. As soon as we shut one down, another one pops back up again. So the numbers are in more detail in our report, but that is the range. Next slide, please. So again, at a high level, our overarching, I guess, recommendation is that it's not broken and we shouldn't fix it. You guys hit it exactly right when you passed this legislation initially, that it has been extremely successful and it has done exactly what it was designed to do. It resulted in the reduction of rates in the individual health market by 32% within the first 3 years. And since then, it has kept rate increases at or under claim trend. So even now, with the claim trends that are existing, we are still almost 22% lower than we were in 2018. And everybody should applaud that. We've also seen, as a result of those rate changes, the enrollment in the individual market has rebounded and has continued to increase at the same time that our uninsured rates have continued to decrease. And that's also a big success. As a result of the implementation and the prudent management of the SRP by MHBE, the unsubsidized rates for comprehensive quality health insurance in the individual market are consistently among the lowest of the nation. So, again, as Adam noted before, we have for the last 3 years been the lowest unsubsidized bronze and the lowest unsubsidized gold. And we're the third lowest this year, the third lowest unsubsidized silver. And it's really important to emphasize that word unsubsidized, right? Because when we look at the real cost, the subsidization is important. And there are many people who receive a level of subsidy from the federal government. But there are also a lot of people who do not receive subsidization from the federal government. And so these rates that we approve on and off exchange. And so people who are not buying on the exchange and therefore can't get subsidies, and those people who choose to buy through the exchange, even though they don't have a lot of subsidy or they don't get any subsidy, but the exchange has such a good connection product that they go to the exchange for that guidance. These are the people who are the most protected by the reinsurance program because they are the ones that would otherwise be paying the full rate out of their pocket. Next slide, please. So what our actuarial modeling showed is that the amount that is currently in place, that 1% assessment, it is a very stable source of funding. It is enough to take the program to the end of our current waiver period. And that's true even if ARPA goes away. And I'm going to talk about that in a second because that's a really important variable here. So even if they go away, if ARPA goes away, we're going to be sitting on a buffer. And that buffer is upwards of $350 million, right? And so as soon as you hear a number like that, people are like, well, wow, like we should be collecting less money than that. But our desire is twofold. One, to make sure that we enter the next waiver period with a solid financial foundation. But most significantly, if ARPA is not extended, so if our Congress is not able in 2025 to be able to extend ARPA, then there is going to be an enormous shock to our system. And that shock is going to exist because during COVID, when the federal government decided to increase the subsidies, they did two things. One, they increased the amount of the subsidies. And secondly, they increased who was entitled to the subsidies. And that part about who was entitled to the subsidies was important because for the first time, really middle income people were entitled to receive some support and benefit. And so as a result of that, there are people who came in to the exchange and who bought insurance at that point. So our desire really is to make sure that we don't lose those people. So the goal is that if those subsidies then suddenly go away, we really risk losing those people. And then you will have, as policymakers, decisions to make about what you want to do. Do you want to shrink the plan at that point? Do you want to use that buffer to buffer the impact of the loss of those subsidies? So we think that those dollars need to be there to make sure that we are prepared for whatever happens in 2025. And if ARPA is increased, we still have the opportunity in 2025 to talk about whether or not there are appropriate changes that can or should be made, either to the reinsurance program funding or whether or not it's appropriate to use some of the monies that are being collected to support other state-based programs. But currently, our view is it's not broken, don't fix it, it's done what it's supposed to do. The next slide, please. I've kind of covered this, which is the ARPA slide. Really the last 2 points that I want to make are, we strongly recommend that we not invade the reinsurance program funds to pay for additional programs. And then the second thing, there should be some amount of money, like the continuation of $20 million or a little more for the young adult program that we can continue to pilot or that we can continue to fund out of the reinsurance program. But we don't have the ability to, fund hundreds of millions of dollars out of the reinsurance program and keep the integrity of that program. At the end of the day, what we as a working group are seeking from the policymakers is your direction in terms of where of these additional market reforms and subsidies you are interested in moving so that we can then provide much more detailed and focused modeling to you. So that is the sort of the not very short, but still relatively short version of the HB 413 report. Again, we are happy to meet with people individually to talk about the details of what is a very dense subject, and happy to take any questions.
Thank you, Commissioner. Does that complete our presentation from MIA? Is there any additional?
We had a short set of slides on HCAT, which we can go through. I'm sorry that we were talkative. If you'd like us to, Ms. Joy Hatchett can go through at a very high level the HCAT program.
Okay. Thank you, Ms. Hatchett.
Thank you. Good afternoon, Chairman Vital and committee members. I am Joy Hatchett, the Associate Commissioner for the Consumer Education and Advocacy Unit at the Maryland Insurance Administration, and I will be very, very brief, but this is an important and exciting opportunity and program that the Maryland Insurance Administration is starting. This is a program that will help people better understand their health insurance coverage and better learn how to use those apparent coverages that people currently have. And we have started this program, and it focuses on several groups. We have been focusing on individuals that were a part of the Medicaid unwind. We focused on individuals that are a part of the undocumented community. But one of the most important groups that we are really focusing on, and I know it's a group that all of you, because through work with your constituents, you're concerned about, those individuals that need assistance actually accessing and using their behavioral health care benefits. That is a group of the population that over the years, we have all known that they need better access to their treatment that they are paying for through their private carriers. And the team that Commissioner Borrain has started under my unit is called HCAT. And what we're doing is we're basically trying to build a group of not just people at the MIA, but partners at other state agencies, other local agencies, also community groups, any type of group or consumer group that is interested in making sure that consumers get better access to their health care. And we're doing it sort of in a phased-in approach. We are talking to state agencies, community members, finding where the barriers are, finding what the needs are. So it's not just members of the MIA saying, this is what you need. Basically, we're listening to the people that need the services and the people that work with those people, basically trying to make sure that we meet people where they are. I could go on for hours, but I will keep it very, very brief. And one of the things that we're really trying to focus on this year also is coming back with data that you can use as policymakers to find where the issues are, to see what needs to be done or what's being done well. We are using some of new technology that will really help us prepare reports and give you the tools that you need in order to make better policy decisions. And the commissioner and I would be very happy and very pleased to meet with any of you at any point to go into more detail about this very exciting program.
Thank you, Ms. Hatchett. Do I have any questions for Ms. Hatchett or anyone else on the panel? Senator Motz.
Thank you, Chairman. I had a question for the commissioner. I was having a hard time hearing, but the commissioner was saying Maryland is leading the country in this, and then Maryland is leading the country in that. think there was 3 or 4 things that the commissioner, you were highlighting. And I was wondering, could you repeat them slowly for me? I want to make sure I heard them correctly.
Yes, so right now Maryland has the lowest unsubsidized bronze level plans in the country. So individual health insurance, the bronze level plans have been the lowest for the past 3 years. They've been the lowest unsubsidized gold premium in the last 3 years. And we are currently the third lowest silver plan premiums.
Okay. And in the modeling for the undocumented individuals, the range was, it was 48, the cost range was 48 million to like 160 million. Got it right here.
Yes.
That's a pretty big range. So the break on that's almost 4 times. I mean, the low end is the high end is almost 4 times the amount of the low end as for a prediction. What is why is that so broad? Why is that? I mean, because 160 million, 40 million, 48 million versus 160 million. I mean, that's, they're not even the same ballpark in numbers. Why is that at that level? Or why is that so such a broad difference?
So the high end is if you wanted to include every person in the subsidization. So if you include.
Say that again. I'm sorry. I did not hear what you just said.
It's at the high end, the largest number reflects giving all undocumented people a subsidy regardless of their age. The lowest end is if it's the youngest people. If one were to subsidize, essentially, for example, bring young adults into provide subsidies for young adults. So the older people are, the larger their estimated claims costs are. And so, the cost of insurance. So it depends on which group, which cohort by age you would want to subsidize. So our report breaks that down by each of those cohorts and provides a number for each of those cohorts. And if you add them all together, you get the highest number.
Yeah. And then a last question. I hear this all the time. These small independent business folks in the independent market with healthcare, and they're at wit's end about the cost of their healthcare. I guess it looked like a 4% increase. Sorry, I was multitasking a little bit. I was paying attention, but I was multitasking. But there was an increase, a slight increase headed for this year. Have you looked at or spent time focusing on that narrow? There have been a number of bills in past sessions. I think it was led by the Chambers of Commerce where they could form a small pool or other things to try to defray some of the costs for health policies. Has that been addressed in today's presentation?
No, it has not been addressed in today's presentation. We are aware that for particularly very small businesses, any increase is problematic. And we do hear from small business owners about the burden of any increase in their insurance programs. Employers do have the ability, not that we're suggesting this, but they do have the ability for their employees to get individual insurance to go, to the individual market. But there are no state or federal subsidies. We don't have a reinsurance program for the small group market. Really, no state has such a program. I think that the difference is that what Mr. Zimmerman mentioned is that those premium costs are typically shared between the employer and the individual. And so neither typically bears the full burden of a rate increase. There are mechanisms that could be deployed, and I would be happy to have that conversation with you and your staff. But the small group market has typically not had the kinds of market reforms or financial support mechanisms that the individual market has had.
Thank you. And if there will be a time, I'd very much like to meet with you and learn some more and get some more insights. But thank you very much for your time.
Absolutely.
Thank you, Senator. If there are no other questions, we are finished this briefing, and Commissioner, thank you and your team for a really good presentation. We appreciate your work.
Thank you.
Thank you. So next, our next presentation, more about health insurance, is from the Health Benefit Exchange, and it's Miss Michelle Everly and Joanna Fabian Mark. So if you'll come to the table, please, we appreciate it. Whenever you're ready, Miss Everly, thank you.
Wonderful. Well, good afternoon, Chair Bidel, Vice Chair Klesmeyer, and Senators. We are really happy to be here today to give you a briefing on the Maryland Health Benefit Exchange, an activity that has gone on, and some of the things that we are focused on coming up. So it's my pleasure to be here, and I've got Johanna Fabian Marks, who's our Director of Policy and Plan Management, joining me, and we'll split the presentation a little bit. Next slide, please. Today, we're going to provide an overview of the Maryland Health Benefit Exchange, discuss our 2023 highlights, including our very successful open enrollment that just concluded on Monday. We'll also provide updates on the Medicaid unwinding, the state reinsurance program, which you had just heard some about, the Young Adult Subsidy Pilot Program, the Maryland Easy Enrollment Programs, all programs that have really helped Marylanders have quality, affordable health insurance. Finally, we'll provide a briefing on Senate Bill 806, the report this committee requested last session to report on health care and dental coverage for Marylanders ineligible for Medicaid and qualified health plans due to their immigration status. Next page, next slide, please. Next slide. So I'll just briefly touch on this a little bit. Everyone on the committee was here last year, so we don't have any new members this year. But just a reminder that the Maryland Health Benefit Exchange was established as a result of the 2010 Affordable Care Act. We are the state's designated marketplace for health coverage. Maryland Health Connection is the marketplace name. Maryland Health Benefit Exchange agency name, Maryland Health Connection, the enrollment platform and eligibility system. It's a place where Marylanders can go and compare all health plans that are available in the individual marketplace. And that's a really important point because individuals in the past that have gone and purchased health insurance on their own, they may have wanted to go to Aetna, our newest carrier this year, or to CareFirst or to United, but they'd have to go to each individual website and really look at what's available, make sure their doctor's in there, make sure that their drugs are covered. The idea of the marketplace is to have one very centralized area where folks can look at all the health plans, look at where their doctor participates, look at if their drugs are available. In addition to that, what we are able to do is provide technology that helps guide that consumer to make the choice of the right health plan that is right for them and their family based on their medical needs. So that's how we help get folks into the right coverage. And then finally, the other area that's a big benefit through the exchange is the entire network of consumer assistance that we have. So we have navigators throughout the state that meet with people individually. We have over, I think this year we're up to 1,800 authorized licensed producers who are experts in health coverage and connect consumers with health coverage. We have application counselors that help, and of course our call center, which has over 200 languages available that we can communicate with consumers in their own language. And we have at minimum at any given time 40 bilingual staff that are Spanish speaking that are available. You heard a little bit in some questions, Senator Motz, on the small business The other opportunity for Marylanders is that we have Maryland Health Connection for small business. And it's a place where small business can come and look at the health plans that are available. They can get qualified to enroll and look at their eligibility for the federal tax credit. This is an area that we have focused on for the last 10 years of really trying to figure out how we can bring affordable health coverage to small businesses. An area we're focused on this year is providing multiple pathways. So you did hear Commissioner Brain say in some instances, it's more beneficial for individuals to go through the individual market right now with the enhanced federal tax credits. So we are working with small employers to say, here's options. You could direct your people through the individual market. We can help you with that. We can help you with getting a small a small health plan. We can help you with getting a tax credit. We are working on individual, they're called ICRAs, individual coverage HRAs that small businesses can put money in. And then of course, our marketing and outreach. So that's a big area for us for this next year. What's important to note about the exchange is that 1 in 4 Marylanders obtain their health insurance through Maryland Health Connection. We have all of Magi Medicaid, that's 1.27 million people in Maryland. And this year we've broken the 200,000 mark in the individual market. I'll talk about more about that in a moment. Over 75,000 folks have purchased dental coverage through the exchange. And new this year as well, we have vision coverage, and we had over 298 people. Well, we did have 298 people enroll in vision coverage. Next slide, please. So I'm going to shift a little bit from 2023 and talk about the end of our open enrollment, which just ended Monday, as I said. The best open enrollment we've had in the entire 10 years. Everything is up double digits. As I said, we had over nearly 214,000 individuals enroll in health coverage. Now, if you'll remember from the MIA slides, when they look at the total insurance marketplace and looking at rates, last year, I think it was about 230,000 was that total individual marketplace. So right now we're hoping that's grown, but we know that over 214,000 have come through Maryland Health Connection for their healthcare needs. That's up 17%. What's more important is new enrollees. We had an increase of new enrollments of over 56,000. That's 64% increase in new enrollments this year. We attribute that. We know we've had over 14,000 folks that we can identify that have moved from Medicaid into qualified health plans. We know that the reinsurance program that helps us provide that lowest cost bronze and gold and the third lowest silver, that's really helped. The young adult subsidy program has helped. Our young adult enrollments are up 27%, and those with a subsidy are up 66%. So you can see these numbers are just phenomenal this year. Our enrollment in our areas that we focus in, Black or African American up 33%, Hispanic up 30%, Asian American up 22%. We did see that our largest growth is in the 200 to 250,000 federal poverty level amount, and that's for an individual between 29,000 to 36,000, for a family of 4, 60,000 to 75,000. And then their second largest growth was in those between 150,000 and 200,000, again, 26% increase. That's a population we figure probably were what we call overscale. They no longer qualified for Medicaid, but we are able to get them moved into acute qualified health plan. Next slide, please. So just to wrap up on the highlights, Maryland continues to provide premiums that remain among the lowest in the nation. We continue to advance technology to remove barriers for consumers to enroll and provide exceptional customer service. And I'll talk about that a little bit in a moment. And through our young adult subsidy program this year, for the first time, young adults could get a $0 premium health plan. And more than 3,000 Marylanders benefited from that. Next slide, please. So let me shift a little bit and talk about Medicaid unwinding. And of course, I'm sure if you have not, you'll get a fuller briefing from Department of Health. The Department of Health is the state's designated Medicaid agency. However, they delegate their authority for eligibility determination and enrollment for their MAGI population, which is modified adjusted gross income, to the exchange. So that's why most of Medicaid flows through the exchange. And we also provide all of their or most of their consumer support assistance through the call center and through our navigators and our folks. Next slide, please. So just an overview on the unwinding. In April 2023, monthly redeterminations began that allowed us for the first time since a public health emergency was put in place to terminate individuals that were no longer eligible for Medicaid. We worked very closely with the Maryland Department of Health to look at those individuals that were no longer eligible and prioritize them to get those that, for instance, say we knew had moved out of state. For those that we knew were way over the eligibility threshold, we prioritize them to get them rolled off first. And most of those were rolled off through the end of September. Now we're winding down to where we're almost getting into our normal cadence of monthly redeterminations that we saw pre-pandemic. I'm really happy to report that there's been a bunch of collaborative work between agencies to really make sure that we keep Medicaid enrollees enrolled in coverage or get them into other coverage if they're no longer eligible. Things that the exchange did, we were able to very quickly change the way we do what we in exchange world called auto renewals. Medicaid world is called ex parte renewals, but we had been renewing them at the household level. And what that meant was if any one person in that household was not eligible, the entire family would get disenrolled. We switched that to look at the individual level. So now it doesn't matter if one person in the household was disenrolled, the other person was evaluated independently, and we were able to re-enroll that person. We saw our automatic renewals or our renewals go from about 45% up to this month, they're up to 63% auto renewals. So what that means is there's no coverage gap for these folks. There's no barriers. They're not going to call the call center. You know, they stay in their coverage. They may call and say, well, I want a new MCO, managed care organization. They may want to switch, but they've got coverage. So that greatly reduces the burden on the consumer. The other thing we were able to do, and we're actually only one of 4 state-based marketplaces in the nation to do this, we were able to implement an auto renewal from Medicaid into our commercial health product. So if they were no longer eligible for Medicaid, but they were eligible for what we call QHP, we got them enrolled into that QHP. Now they still need to take action because we can't what we call effectuate coverage for them. They need to pay the bill and have that effectuated. But again, we saw, I said earlier, 14,000 people that we were able to move over in that. And then also we were able to use our technology. We have what we refer to as our marketing portal, but it allows us to send texts directly to consumers, emails directly to consumers, to help them know that they have to take action inside our portal. If somebody's trying to fill out an application and they're getting stuck, we right at that moment can send them something to say, how can we help you? So all the tools we've had available to either keep people covered in Medicaid or to get them moved over to QHP. Just make sure I didn't forget anything on that. All right. And I'll just say, one very important point, Maryland's collaborative efforts have resulted in Maryland being in the top 5 states nationally for the percentage of people that were either renewed or retained in their Medicaid coverage. So again, we've done a great job making sure we found people, kept them covered and in health insurance. And with that, I'm going to turn it over to Johanna, who will provide updates on our affordability programs.
Thank you, Michelle. And as Michelle mentioned, I'm Johanna Fabian Marks, Director of Policy and Plan Management for the Exchange. The Commissioner and Adam covered some of the material here on the reinsurance program and the Young Adult Subsidy Program, so I may skip over some information so as not to repeat ourselves. But as you know, the reinsurance program has been in place since 2019, very successful at reducing rates over that time period. And as Adam shared, rates are still down more than 20% compared to where they were in 2018. Next slide. As you're aware, reinsurance works by reimbursing insurance companies in the individual market for a portion of their claims costs. The formula for that reimbursement is determined by the MHBE board annually, and there's some information here on the slide about what those parameters were over the years. Next slide. In terms of the scope of the program, I always think it's just interesting to point out on the left side, and this is 2022 data, which is the most complete year of data we have. We're still getting our 2023 data completed. So for 2022, about 6% of the market, about 14,000 people, that little blue sliver on the left pie chart, qualified for a reinsurance payment, meaning they had annual claims that exceeded $20,000. So just 6% of folks are driving these high costs. For those individuals, they accounted for about 2/3 of costs in the individual market. So on the right, you can see the red and the pink slices of the pie are their costs. So that 6% equaled 2/3 of the cost. The reinsurance program reimbursed half of that in the dark red. So overall, 1/3 of claims in the market. And then insurance carriers were on the hook for the other half for those high cost enrollees. So reinsurance in 2022 paid out almost $500 million, which was about 1/3 of claims in the market. So certainly a very significant program, and you can see why it's having the major effect that it's having. Next slide. As the Commissioner and Adam shared, this is translated into some of the lowest premiums in the nation, about 25 to 30% below national averages. And there's more detail in the graph showing how our premiums in the solid lines by metal level compare to national average premiums in the dotted lines. And we're substantially below the national average on all fronts, and lowest or nearly the lowest in the nation. Next slide. Our enrollment, as we've mentioned, has rebounded after falling in the run-up to the launch of the reinsurance program. When the state decided to take action, you can see that dip around 2018, 2019, and then growth ever since. And this doesn't include the phenomenal growth that Michelle has just shared with you for 2024. But overall, our total individual market enrollment is up about 21% since the reinsurance program launched, and that's as of 2023. Next slide. This slide provides a synopsis of the financial status of the program and our projections for it through 2028. The green and blue bars show that annual funding coming in to support the program. Those are actuals through 2023 and then projections for 2024 and beyond. The blue section of the bar is state funding that comes from the 1% reinsurance assessment. And then the green portion is federal pass-through funding that we get from the federal government to support the program. You can see that that's a very significant portion of our funding, which is fabulous. The red line shows the annual cost of the program. You can see it grows year over year in line with inflation and market trends. What looks like black line on this slide is the state reinsurance fund balance. So that 1% is accumulating. You can see in the first 3 years of the program, the incoming funding, the bar, outstripped the red line, the cost. And because that funding was exceeding the cost of the program, we were able to build up that reinsurance balance and indeed funded the program solely with federal dollars in those early years. In 2022, that was the first year where our funding coming in didn't quite meet the cost of the program, and we had to pull down on that balance to fund the program. But going forward, 2023 through 2025, we anticipate funding continuing to slightly exceed the cost of the program. In 2026, when the enhanced federal subsidies under current law would end, we anticipate the federal funding will fall somewhat and we would be slightly below the cost of the program, then would be pulling down on that accumulated state fund balance, but still ending the waiver period. The program is improved for 5-year stretches, still ending our current waiver period in 2028 with a balance of around $350 million, as the commissioner indicated. So, comfortable with where we are, hopeful that the federal government will take action to extend those enhanced subsidies. If that's the case, we anticipate funding would continue to meet or slightly exceed the cost of the program in 2026 through 2028. So we would not need to pull down on our balance, but these are dynamic projections. We get more information every year. It's still a relatively young program, so these continue to evolve. Next slide. So moving on to our next affordability program, the Young Adult Subsidies Program. As you're probably aware, this group was chosen to be a target for additional subsidization because they're the largest group by age of uninsured individuals in the state, accounting for over 40% of uninsured adults. So that 18 to 34 demographic, more likely to be uninsured, but also lower cost to insure because they tend to be healthier. So if we can get them into the market, it brings down costs for everyone because it reduces the average cost. So there's, benefits from many facets to increasing our insured rate among young adults. Next slide. We launched the 2-year pilot program that started in 2022 and was extended for an additional 2 years. So it will end at the end of 2025 unless action is taken to continue it. It provides state subsidies on top of the federal subsidies to reduce premium costs on a sliding scale. So the youngest and lowest income young adults are paying the least among these 18 to 34-year-olds that we're targeting. And it's funded with up to $20 million a year that's set aside from the state reinsurance fund. Next slide. The one thing I'll focus on here is just to point out that for 2024, we expanded eligibility for the program from 18 to 34 up to 18 to 37. So made it slightly more generous for the younger folks in the program and available to slightly older folks. And then here's just a snapshot of data through 2023. You can see that about 30,000 young adults benefited from the subsidy program in 2022 and 2023. Those numbers are up substantially for 2024, as Michelle shared. Just looking at the 18 to 34 cohort, comparable, year over year, not looking at the expanded age group for this year. that number of individuals getting the subsidy is up 40%. So that's substantial. You know, our overall enrollment growth was up approximately 17%, but that young adult subsidy enrollment growth has really, really blossomed. Next slide. And then this isn't an affordability program per se, but another effort to get people enrolled in coverage that the legislature, you know, tasked us with implementing our easy enrollment programs. One, you can check a box on your state tax return to qualify for a special enrollment period, and we'll reach out to you to help you enroll. And then next slide. We implemented a similar program for individuals receiving unemployment benefits, where they can check a box on their weekly unemployment claims documentation to indicate they're interested in help getting coverage. We get that information from the State Department of Labor and then reach out to assist in getting folks connected to insurance. We've had more than 13,000 enrolling coverage since the launch of the program on the tax side, about 3/4 in Medicaid, which is amazing because it's a free program that they were eligible for but may have been unaware of. And then on the unemployment side, we've had more than 18,000 individuals enrolling coverage, again, mostly in Medicaid. And that's really performing remarkably because it only launched in the summer of 2022. And that's a wrap on my section. I'll hand it back to Michelle.
So I will talk about the Senate Bill 806 report, which was came out of this committee last year. And Johanna was heavily involved with working with the Department of Health on this report. So if there's any questions, especially when we get into the detailed numbers, she's right here to answer. So this, as you remember, came out of this committee. It was to look at how we could provide coverage, if we could provide coverage for those that in Maryland are otherwise ineligible to qualify for Medicaid or for commercial health plan. So federal rules with some limited exceptions limit eligibility for Medicaid and private plans to non-US citizens and lawfully present non-citizens. As a result, in Maryland, about 112,000 people are uninsured and ineligible for Medicaid and private plans because of that immigration status, and that accounts for about 1/3 of the remaining uninsured in our state. Last year, the legislature passed Senate Bill 806 requiring Maryland Department of Health and MHB to examine different options for expanding coverage for undocumented individuals. And particularly the legislation directed us to look at the cost and impact of expanding coverage through Medicaid or through the exchange for 3 groups: all ages, under 21, and 65 or older. We have submitted that report in December, so you have it. It's much more detailed. There's a lot more information than what I'll present today, but I'll share with you some of the high level items from that report. Next slide, please. Okay, I promise this is the most detailed report you'll see from us today. So this is pretty wonky, and we'll try and make it a little bit easier. So this report is broken into 2 age groups for this population. We have all ages on the top, and then we looked at the under 21 age group on the bottom. And these are for income eligible or based on their income eligibility, whether they'd be eligible for the full Medicaid or for QHP, and if they're not eligible for Medicaid or MCHIP for QHP. So we looked at different scenarios, and we looked at, again, if we did all ages, and then we segmented a little. For each scenario, for each scenario, it's thank you. I appreciate that. For each scenario, we estimated the enrollment. To get these enrollments, we first estimated the undocumented uninsured population by age and income. Then we estimated the uptake. That is, what percentage of those individuals do we really think would actually enroll? It's important to know that these estimates are highly uncertain. First off, we don't actually have precise data on the total number of the uninsured, undocumented individuals in the state. Second, it's very difficult to estimate what percentage of eligible individuals are likely to enroll. As a result, you can see that in the average enrollment column, we have a bolded midpoint estimate with bracketed low and high estimates. Looking at all ages, but only those below Medicaid income levels, we estimated about 20,000 individuals would enroll in a full Medicaid benefit package. If offered a QHP instead, we estimate about 14,000 would enroll. And that was, again, because of the cost to enroll in that QHP. And also the QHP is a less generous benefit package. Looking at all ages, but those above Medicaid income levels, we estimated about 13,000 individuals would enroll in a QHP. Again, if we look at only those under age 21, you can see that the enrollment ranges from about 6,000 down to 100. The reason for the minimum enrollment in the last group under 21 and above Medicaid income thresholds is because the total population in this group is much smaller. We estimate that most undocumented individuals under 21 have incomes under the Medicaid threshold levels. Moving on from enrollment estimates, we next estimated the per member per month costs in each scenario. These estimates are much more solid. We're assuming that no federal funding is available. So these are state cost estimates. For Medicaid, we assume the state is paying the cost of the Medicaid coverage using 100% state funds. For QHP options, we assume that the state is providing premium and cost sharing subsidies equivalent to those provided by the feds to legally present individuals. The QHP cost also incorporates projected cost to the state reinsurance program. For full Medicaid benefit package, we estimate average PMPM costs of about $580 for all ages, or about $300 for those under age 21. As you can see, the QHP PMPM cost estimates are higher than the Medicaid costs. Then, using the estimated enrollment and estimated per person costs, we estimated the total annual costs. In this table, we're showing the estimated calendar year 2025 costs and the total costs over 5 years from 2025 through 2029. Again, because the enrollment estimates are so uncertain, we provide a midpoint estimate and show the range of low and high estimates underneath. For the full Medicaid benefit package, we estimate a calendar year 25 cost of $128 million, or about $20 million for those under 21. We also did a rough estimate for those under 18, which came out to be about $15 million. And although the report required that we do it under 21, but we did feel it was important for the committee to know what that cost under 18 would be, which is that $15 million. Although the per person cost for the QHP benefit package is higher, the total estimate costs for the QHP benefit packages are somewhat lower due to the lower estimated enrollment. So again, when you're looking at the PMPM costs, they'll be higher, but the total cost lower because we are assuming less uptake in those plans. All right, so that's the media slide of the presentation that really gives you a lot of the detail. So what did we consider when we were looking at coverage, providing coverage for folks otherwise ineligible? So we looked at what would impact commercial health plans. We know that federal subsidies would not be available for this population. There may be potentially some Medicaid funding that would be available through what's allowed for emergency services today for undocumented population, but that needs further assessment. It would need to be approved by CMS, and so that's an uncertainty. We do know that we need to submit a 1332 waiver to even allow undocumented individuals or people ineligible for coverage to enroll through the exchange, and that the CMS has told us very strongly they would like legislative authority granted for us to do it. I know last session there was some commentary about that. Well, the exchange can file this 1332 waiver on their own, but CMS is telling us, no, we want you to get legislative authority. So that's important for you to know. Not a big lift for us to do that work, but that's another consideration. Providing coverage through Medicaid, again, would have the same issues on the federal funding. It would have to be covered with state funds. Possibly the funding that's allowed for emergency services could be used. And finally, expansion of coverage may yield other savings. So they're difficult to quantify, but savings that would be a result with the hospital uncompensated care would likely, maybe, we reduce as we anticipate. And then just the other intangibles of increasing the wellness to our communities, greater ability for people to engage in economic opportunities with better health. So those are some of the intangibles. So the conclusions, and again, this is high level, you have the report. The conclusion is it is less costly to provide that coverage through the Medicaid program when you're looking at a PMPM basis. However, based on income levels, not everyone would be eligible for that coverage through Medicaid. So having an avenue through the exchange for those that are above what Medicaid may cover would be important. And that's where the 1332 waiver comes in. Covering all Marylanders, eligible Marylanders, if you've seen in the numbers, is extremely costly. And the Department of Health and the exchange, after working on this report, really do encourage looking at moving forward in baby steps, maybe looking at certain segments of the population that would give us the opportunity to really look at what the expenditures are going to be, how predictable our assumptions are, and better refine our data on take-up rates and enrollment and our cost projections. So that would be the recommendation from our agencies. And we'll stop there. We have given you an awful lot of information and happy to take any questions.
And thank you very much for both of you for your work and your presentation. And it's really important work. And we're just amazed how well your exchange is functioning for all of our citizens. So thank you for that. I do have a question from Senator Reedy.
Thank you, Madam Chair. And yeah, I echo thank you for the presentation. And the exchange really has come a long way since we had some problems when it first got started. And a lot of that's been worked out over the years. And you guys are doing a good job of keeping it running efficiently. I have some questions about this chart that you've shown us relative to the sort of the projected enrollment and cost of both Medicaid and QHP here. So am I understanding that you estimated how many people would be, if we did all ages, you're estimating 20,000 people would be income eligible for Medicaid, for full Medicaid, and about 14,000 for QHP? Or is that, would those be added together to get the full number?
So those are alternatives. So it's the same population of folks who are income eligible for Medicaid, and they were saying they could either get Medicaid or we could offer them a private plan that they would have to pay for.
Does this, okay, so it's not, for example, you have 20,000 and 14,000 as estimates. It's not 34,000 people.
No.
It's either or.
Yes.
Good. That's good to know. On the 20,000, what if they're people who, we're assuming a lot of these folks are not eligible. Their income's not going to get them beyond that level where they could just buy. Can they buy through exchange now without subsidy?
They're not permitted to buy through the exchange now because federal law prohibits it. They could buy off exchange
Right.
and pay full price.
Okay, so let's say if we went with the 20,000 number going with full Medicaid, we're saying that is if it was 20,000 people, because your range is between 9,000 and 31,000. And I understand picking a number, an estimate, which is good. So $128 million a year is what that would cost if they were if Medicaid eligible folks were able to buy through the exchange that are not here legally.
That's correct. And that's for 2025 and 2025 numbers.
Okay, so it's about a $700 million 5-year. And then the QHP option, we're thinking that would be 14,000 people. And that would be about $105 million a year to the taxpayer, correct?
Correct.
Okay. I guess my question with these two categories of folks is, can they visit right now? If you're here, if you're an illegal immigrant here, you're undocumented, and you're here, we hear a lot about the emergency room. People can just come to people go to the emergency room, and we know that's uncompensated care is a problem. Can they visit a federally qualified health center?
Yes.
Is there anything that prohibits someone from, there's not a federal law that says you can't go to a federally qualified health center, right?
No, and the FQHCs are available, but typically they offer primary care, limited care. So it's not a full benefit of services.
But they can go, but if somebody had an emergency, they would need to go to an urgent care and emergency room anyway, correct?
Correct.
Okay. And then, so how many I looked up, there are 107 federally qualified health centers in the state, many of them in population centers, but there's also there's one in Federalsburg in Caroline County, which is a very small town. So there are other alternatives to providing taxpayer funded insurance to people who are not following current immigration law.
That is correct, but again, I think the difference is the level, the amount of care. So
Sure.
again, if you go to an emergency room, the obligation is to get someone stabilized. So you may have a heart condition, we can get you stabilized, but once you leave, you still have that heart condition and nothing's taking care of that heart condition. FQHCs primarily does primary care. So again, the ability in that situation to see a cardiologist, to have follow-up, tests, et cetera, would be limited. So that it's the breadth and
That's
depth
the
of
issue,
coverage.
right? The last question I would have, and I know you all are implementing and giving us the data, so this is more of a policymaker question probably, but was there any account to if this would be limited to people who've lived in Maryland for a certain amount of time, or it would just be anybody who is here could be in this number?
And those would be policy decisions that you all would make.
And I have one last question, Madam Chair, thank you, or Madam Vice Chair, thank you. Just one last question about the waiver or requesting the waiver from the federal government. And I actually appreciate the needing legislative authority. I think that's smart because you don't want to do something from the agency side without getting a clear authorization. You said to offer QHP, we would need the 1332 waiver. But even with the waiver, it says here on the slide, no cost to the state if we got the waiver. But I thought you said the waiver, you still can't use subsidy dollars for
Right,
illegal immigrants?
So right now, the federal law is that if you do not have proper documentation to live within America, you are not able to purchase health insurance through the exchange.
Okay.
Even if you pay for it without any tax credit, you simply cannot purchase it.
That's federal law.
That's federal law, right? We can ask that requirement be waived through the 1332 waiver process. The state of Washington did that. We would like that opportunity because what's important to allow everybody to purchase health insurance through the exchange, even if they don't qualify for a tax credit, is again, what I spoke to earlier, the power of that marketplace and being able to see all the plans and compare the doctors, compare the drugs, get all that wraparound consumer assistance. So yes, even though someone could go to United or Aetna or CareFirst and buy their own plan, they're losing the benefits that are part of the exchange.
Okay, so with that waiver though, we still wouldn't be able to get Medicaid funds, or you're saying that Washington State was able to get some Medicaid funds?
It's something that we have not explored yet.
Okay.
There is some suggestion that because Medicaid pays for emergency services for undocumented, if we put them into a commercial plan or Medicaid, we might be able to get some reimbursement for those types of services, but that.
Not
needs
clear at this point, though.
Correct.
Okay, thank you very much, and thanks for the work and the presentation. Thank you, Madam Chair.
Okay. Senator Lamb.
Yeah, thank you, Madam Vice Chair. Good to see you again, Ms. Everly. Just a follow-up question on this 1332 waiver. I know we'd had some extended conversations about this before. And I guess it sounds as though the federal government, CMS, has made very clear that they would much prefer a statutory kind of backing to this.
Correct.
Is that correspondence that you can share with us? Do you have correspondence there that comes back to us?
I'm sure we could get it if we can re-ask for it. I'm sure we don't have it, but yes. And we had many discussions with them and they said, no other state has ever done it without that legislative authority.
Mhm.
And so they strongly urged us to get it, but I think we probably have an email somewhere.
Yeah, we had some phone calls and some informal email exchanges.
Okay. All right. If you could follow up with us, that'd be great.
Yep.
Thank you.
Any other questions? I see none. So that ends our briefings for today. And thank you very much. I think you guys do a super job.